Hi, distinguished panel. I'm Jonathan from Kelsis. I've got two questions, one for Dr. Kenneth, the other one for Dr. Saiful. So Dr. Saiful, IKN has about tens of thousands of patients annually that come to you at late stages, so there's always a need for your work given the continuum of care that you've shared on palliative. How do you deal with that so much patient volume? Because there's only one Dr. Saiful, and maybe there's so many team. Maybe you can share insights, and especially in how you cope with that patient volume, because I think that could be very useful for others that are thinking of providing that service. The second one for Dr. Kenneth is, Sarawak government has talked a lot about that multi-billion hospital that's being built. We've heard about that. Can you share what's happening on the ground? Because that's very exciting. Where we heard that the state government is financing the building, the infrastructure, the building of this billion-dollar cancer hospital. What's happened to it so far? I mean, since you're so close on the ground.
Thank you so much for the question. And yes, we have a lot of patients coming through our doors in IKN. We have about 1,700 referrals to palliative department every year, that is. And that's not inclusive of other hospitals where we are visiting. We are visiting Hospital Kajang, we are visiting Hospital Cyberjaya, and I'm still doing a weekly visit to Hospital Melaka at the moment while waiting for a new person to man the department over there. So if we add up all together, it'll be close to 3,000 per year. But we work in a team. We work in a team. There are 3 specialists over there. We used to have 8 medical officers, but with the current issues with manpower and human resources, we have 5 medical officers at the moment. And not just doctors, we have 8 nurses who actively do home visits every day. We have clinical psychologists, we have 2 of them. And we also have volunteers as well as spiritual groups who also follow us for home visits, and other allied professionals who also follow us during home visit, physiotherapists, dietitian, as well as occupational therapists. I hope I'm not missing out any of them. There's too many of them at the moment. But that's the beauty of it, that it's not just doctors. It's not just nurses. And I think we need to move away from doctors and nurses as the solution for all these issues. We're not. We can't be working in silos too. We need to be able to talk to other departments. We need to be able to talk with other allied health professionals who might be able to help with our patients too. Oh yeah, there are also pharmacists involved with our home visits too at the moment. We have a daily discussion in our department before we start our ward rounds, where we discuss all of our new cases that are referred from the day prior. And we will try to delineate what are the issues that needed to be addressed for these particular patients. And if we go for home visits, we will have a discussion after that home visit session so that we try to find out what are the issues that needed to be addressed here. And from that point, we will then talk to our team members to see who are the team members that can be involved with this patient care. Who are the people that we needed to contact to get in touch with the family members as well, and we delegate. That's the beauty of it, we delegate. But at the same time, we are still supporting them with their clinical needs. We are still seeing them for their symptoms control, their medications and all that, but we also tell them, well, we'll get the ustads to come down because you are asking us about how to do your prayers in your current condition. Or sometimes we get the welfare officer to come down and have a look at you because you've tried arranging your SOCSO application or EPF application, but there have been some hiccups about it. And we go about it that way. And if there are any issues, we make it an open door policy where any of our allied health professionals can just talk to any one of the doctors or nurses to try and raise up any issues so we can find other ways to try and manage that particular solution. The one thing I usually tell my members, my team members is, we're not looking for a real solution that will 100% solve the whole issues here. We are just trying to address this problem. And for a lot of patients, just trying to address that problem and getting that little steps in usually helps them in one way or another. And then we'll do that. Yeah, because sometimes it can be unrealistic. Sometimes it can be, oh, I want to be able to walk again. And you can see this patient is very cachectic, and you can see that they may not be able to regain those function. Then we'll get our physiotherapy to help with some of the things that they may need to change with their current condition. And we'll probably get our clinical psychologists to be involved with trying to see what are the issues with now losing functionality with this patient is like for them. Yeah, so we do it that way, working as a team and being able to talk to one another and have an open discussion about our patients as well as their caregivers. I hope they addressed it.
So now, before I answer the question, I actually like to echo Dr. Saiful's very important statement on not relying on doctors to run a lot of our cancer services. My unit started off with myself, two medical officers who were just busy running clinics and theaters. So how did the cancer navigation idea came through? It was actually by an effort of one of my senior nurse. One senior nurse who somehow have the kind of passion and capability to keep track of a lot of patients. Mr. So-and-so is due for a CT scan next week, but he haven't shown up to collect his forms. This guy is due for a radiotherapy appointment, but he's missing. So, and from there on, we slowly built the momentum and start to get it properly arranged into a system, and it becomes a very good workflow. So that was how we started. Now, the second question, I don't think I have the liberty to share a lot of details, but what I can share is that, so for myself, I am one of the committee members of the technical team. So what technical team do is that basically when you need to design a new hospital, so stage one is that you need to draft out the medical requirements. So we need to write proposals and say how this hospital is going to be like. What do you need? What are the physical spaces? What kind of services needs to be included? Until the details of how many rooms we need, how many beds, which room is dedicated for what purpose. So it took, that exercise happened in 2022 to 2023, with only a few of us head of clinical services in Kuching. In those days, those who were the stakeholders in the cancer center project. The main team was the oncologist, the hematology team, pediatric oncology, and surgical oncology, which I had to take it up, being one of the few surgeons who actively operate on cancer. So it became my responsibility to draft those. After that, the next step would be to bring these requirements and incorporate it into an actual physical hospital, and that we need the JKR engineers to come in. Then I can assure you it is not easy for doctors to communicate with engineers. They have no idea what we mean in all these medical reports, and we don't know what they are trying to tell us when they talk about structures and spaces and so on. So that is a long process. But what I can tell for sure is, you are right that this hospital has been given the green light by Prime Minister. It has been given the green light by the Minister, the current Health Minister. It is now ongoing planning, architecturally and structurally. Sarawak government has agreed to fund about probably 1.2 billion into this project, and the terms of how it will be run in the future, I think probably this is where I probably could not share much publicly, because in fact it involves much higher pay grade than MIRA. So, but I hope it will happen in this decade. Then we will be looking like a model of a second IKN in the East Malaysia, where we can push further progress. Thank you.
So any more burning questions? Yeah.
Thank you, doctors. I'm Dr. Shamli from Magna. Actually, my question is for Dr. Saiful. Dr. Saiful, do you think that in a public hospital setting for palliative care referral, does it usually come on a later stage? Like as you mentioned, they only refer when it's an end of life care. And if so, like at the end of your slide, how you emphasize early palliative referral, how can we create that awareness among the medical professionals in the public hospital?
Thank you so much for that question, and I think yeah, that's part of my frustration where sometimes patients are referred very late to me, and I think the many a time when I go to different conferences and different courses is I try to tell people when you already identify somebody is or has an advanced stage of illness, think about palliative care. Don't wait until you can't give any more chemotherapy to refer them to palliative care. Don't wait until you can't give any further radiotherapy. Don't wait for that best supportive care word to come out before you think about palliative care. Palliative care can come alongside disease-modifying treatments too. Yeah, as long as the aim of the therapy is palliative in nature, you're not trying to cure that illness. How to do it is we all need to learn about it. I'm a big believer that palliative care can be provided for the early stages by any general physician or doctors. I remember when I first worked in Malacca before, I was working in Malacca for about 2 years before I came back to IKN. And one of the questions that was given to me by the pharmacists as well as the administrators was that, should we lock syrup morphine so that only a palliative physician can give it? I was like, no, why do we want to do that? It's list B under the Ministry of Health setting. And it's list B for a reason. It's list B so that people are confident about prescribing it. So that people learn how to prescribe it. We shouldn't lock it to just palliative care to be able to use them. I would love to think that by the time patient reach me, I would be thinking about something else or a regular dose or higher dose of morphine rather than starting them. To me, starting morphine should be the same way as thinking about starting insulin for a diabetic patient. It's a basic human right for patients who have palliative care needs. It shouldn't be a palliative specialist work, but we haven't gotten there. And the reason why we haven't gotten there is because we haven't talked about where should we start teaching our medical professionals about palliative care. There was a recent updated atlas on palliative care services that you can find on the International Association of Hospice and Palliative Care website, where they look at the different provision of palliative care in different parts of the world. So the Asia Pacific one was just launched last April in Kuching during the Asia Pacific Hospice Conference. And one of the deficiency that we noticed during that work to try and see what are we lacking here in Malaysia is that there are very little exposure to what palliative care is in the medical school setting. And we need to unify the curriculum so that our medical students also learn what palliative care is. We need to unify the curriculum in our nursing school. Our nursing school is even more abysmal. There's so very little exposure to what palliative care is when people are still at the point of learning to become a nurse. And can you imagine the amount of work that our nurses are actually involved with when they are looking after palliative care patients? It's actually a lot more than what doctors have to deal with. So we need to look at that. We need to look at where shall we start this education, because at the moment we're starting too late. We're starting at a point where people think that they know what they're doing when they don't. Yeah, so but that's a bigger task, because I don't think that task can be headed by palliative care physicians alone. I think we need to open up these discussions to administrators too, to physicians as well as academicians in universities too, to the nursing board as well. We need to open that up, because at the end of the day, the four arms of medicine is clear. There's screening processes, there's treatment processes, there's rehabilitative processes, and we're doing quite good on all that. And then we come to that other arm, the palliative arm of medicine. Where are we in that? Still a work in progress, but I hope at some point we recognize that all of us have a role to play here, because I can be saying as much as I can about all this, but if we haven't recognized that all of us have a role to play, then I haven't gotten there yet. and hopefully we all recognize that too.
Thank you. So I have a question to Dr. Muhammad Faizal. So what is your take on the legal and also medical possibilities on the surrogacy in Malaysia, especially those patients in advanced malignancy, you can say colorectal or even lung cancer?
Okay, basically, when we talk about oncofertility, the first and foremost rule you need to know that not everybody have a chance to become a mother. So when we have an oncofertility service, some of them was thinking that as long as I have cancer, regardless the stage, I can preserve my oocyte, eggs, or even sperm. So it's not that so, because in Time magazine, I think in 2022, the ethics of oncofertility have been published there, whereby one adenocarcinoma cancer of endometrium patient from US went to India and they did surrogacy with the eggs, and the baby was born 5 years old and the mother passed away. So who want to raise this daughter when the mother is already passed away? So this is the ethical of oncofertility. So thereby in our oath, when we want to produce oncofertility, we incorporate the term of adoption. So I published a paper in 2022 in Japan. How is the trend of adoption among cancer patients in all Asia countries? So with that, I know that JKN is searching for adopted parents for all these orphans in Malaysia. So that's what my oncofertility service is. So for surrogacy, if you're asking about surrogacy, we as a Malaysian Muslim country, we didn't do surrogacy. But I created an induction lactation clinic in my oncofertility unit, whereby if the patient have no hope for for freezing oocyte or anything, but they want to become a mother, I will write a special letter to JKM and then ask them to have an adoption. Then I will go for induction lactation, and then the Jabatan Agama Islam Selangor have come up with a special card for lactational mother to say that the mother is the make mother for the children. So this is how we do it. So for me, the surrogacy is one thing. The second thing, they ask me, how about this oocyte donation, sperm donation? So based on the fatwa that we involve, for Malaysian fatwa, still single man and woman is haram to go for freezing. But when I come back, I try to fight with the fatwa, academician. So we try to fight for the fatwa, but we lost. But we go to Datuk Dr. Zulkifli, at that time is a Mufti Kuala Lumpur. We come up with muzakarah. Muzakarah means that only the state will follow. For example, is muzakarah from Kuala Lumpur, Kelantan might not be agreed, Perlis might not be agreed. So I have a Kelantan patient that need to come all the way to KL just to do it, because muzakarah in KL said that single man and woman can freeze their gamete, provided there is a cancer who can jeopardize the function. So that's why Dr. Zulkifli, the wife is a physician, I think a radiologist, so he know a lot about the term of medical. So we have a KKM meeting with the Mufti, then we allowed that. So that's why at this moment, donation and surrogacy is not allowed. Even in the country who's not Muslim, surrogacy will actually interfere with the ethical services of the oncofertility, based on the experience that they have worldwide.
Just if I refer case to HUKM, so how much the financial?
My yayasan tak ada duit. Okay, so basically, what I'm trying to do is, why I'm still here in government, so-called KPT. Because when I come back, I receive a lot of offer to go to private, because this is considered commercialization. They can make additional service of that. So, but the thing is, I want to try to put some hope first by controlling the price. So to be honest, I started to start the sperm freezing is only RM250, RM250 je. So if kau tak ada duit pun, aku refer ke bajikan, approve on the spot. Okay. But if you see, if sperm freezing in private is at least 3,000. Okay. Oocyte freezing for us from stimulation, everything is only RM8,000. But in private, when I work, is 30,000. Ovarian tissue freezing, I started with Japanese product and everything, is only 8,950. But when some of the center asked me to be visited there and offer this service, they quoted 35,000. So that's why, why I asked to refer to UKM is because of the price is cheaper. Of course, you said, alah, Sanford pun ada, Alpha pun ada, that kind of thing. But they are just reproductive. They are not oncofertility, whereby they just freeze your egg,
Kalau patient tu mati ke, patient tu upgrade the stage ke, dia tak tahu pun. Dia just wait, dah bayar freezing fee belum? 3,000 kau hutang, macam tu je. But for me, patient take or not the onco-fertility, I will still follow up the patient yearly to see what is the stage and everything. But sometimes they said to me, Prof, I think I don't have any, I didn't do any freezing, but I really want to become a mother. What should I do that? So I will search for the ovarian function, what blood test, everything, or the oocyte is already 0, then I will say, never mind, we can just go for adoption, and I refer you to the lactational clinic. So that is how I do.
Thank you very much to all the panel. Very interesting conversations. I myself learned a lot today from the cryo freezings and also for Dr. Voon and Saiful. Time's up. Thank you very much. We meet up in the next meeting. Thank you.